So first line management of ALK rearranged non-small cell lung cancer. So we'll come to the incidence of lung cancer in India in 2020. Approximately 72,000 patients were diagnosed as a CA lung, and out of this, 67 patients got mortality in 2020. In North Indian patient cohort, ALK gene rearranged lung adenocarcinoma was approximately 7% after the EGFR and KRAS mutation. In the timeline, the ALK rearrangement with the EML4 translocation was discovered in 2007, and crizotinib, which was the first, got approval in 2012 as the first generation ALK inhibitor. And after next 6 years, we got another ALK inhibitor, second generation, like ceritinib, alatinib, brigatinib, and they were approved also. In 2019, third generation lorlatinib was discovered and got approval in 2021 for use in first line, ALK inhibitor. So ALK rearranged non-small cell lung cancer is 3 to 5% of all advanced non-small cell lung cancer, and which are more common in the younger patients and never or light smokers in adenocarcinoma histologies. Commas also they can present, but very rare. So first generation ALK inhibitor is crizotinib, second generation is ceritinib, alatinib, and brigatinib, and third generation lorlatinib. As per generation, potency and activity against ALK mutations are increased, and CNS penetration also improved. First, come to the first generation ALK inhibitor crizotinib, the profile 1014 trial, in which crizotinib was compared with the standard chemotherapy, pemetrexed and carboplatin, and PFS was 11 months versus 7 months, which was statistically significant. And in updated OS data, this median OS was not reached in crizotinib arm, while it is in chemotherapy, it's approximately 4 years. And in Ascent 4 trial, and PFS was almost double, 8 versus 16 months. OS data is also not estimable. The hazard ratio is 0.73 in updated data. Then alectinib in ALEX study was compared with the crizotinib. Previous two were compared with the chemotherapy, while this was compared with the crizotinib, already established ALK inhibitor. In this, PFS was increased up to 4 times, 11 months versus 35 months in both the arms. Alectinib is better than crizotinib, 34.8 months versus 10.9 months PFS. Overall survival is immature, with the hazard ratio is approximately 0.67. So these are the randomized trial of the first and second generation TKI we discussed. In ALTA-1L trial, brigatinib was compared with the crizotinib, in which PFS was almost double, 11 months versus 24 months. Now, this lorlatinib was rationally designed to address the unmet needs in the ALK positive NSCLC. These unmet needs were first, metastatic brain disease. In untreated ALK positive NSCLC, approximately 20 to 40% patient got brain metastasis. And the second need was the acquired resistance to the already established ALK TKIs. For these two needs, lorlatinib was designed. And this lorlatinib has effective CNS penetration and retention. And second point, it binds with a very high affinity to the most ALK resident mutation. Crown study was done, this is phase 3 trial, compared with the crizotinib. Lorlatinib is compared with the crizotinib. Key eligibility criteria is stage 3B to 4 ALK positive NSCLC, chemo naive or treatment naive patient with the good performance status with the asymptomatic brain mets. Randomized in the ratio of 1:1, and stratification done by presence of brain metastasis and ethnicity, Asian versus non-Asian. Primary endpoint was the PFS, progression-free survival, by the blinded independent central review. Baseline characteristics were well matched between the both arms. So now come to the 36-month follow-up data, which are presented in 2022 only. In ITT population, we can see 3-year PFS is 63.5%, approximately 3.5 times, more than 3.5 times in comparison with the crizotinib. In crizotinib, it's only 19 months, and median PFS is still not reached. While it is in crizotinib, it's 9.3 months. And overall response rate was 77 versus 58, almost 1.5 times. And median duration of response is not reached in the lorlatinib versus it is less than 1 year, 9.6 months in the crizotinib. And we can see in this subgroup analysis, in each and every subgroup, lorlatinib performed much better than the crizotinib. Each subgroup, including whether brain mets present or not, whether Asian or non-Asian, whether male, female, or age, smoker or former smoker, metastatic, and adenocarcinoma. Each subgroup, lorlatinib performed much better than the crizotinib. So BICR, blinded independent central review, assessed PFS. We can see it is better in the lorlatinib. It has not been reached. Median PFS has not been reached in the lorlatinib arm in both conditions, whether it is brain metastasis present or without brain metastasis. You can see with brain metastasis crizotinib arm, median PFS is 7.2 months, while in lorlatinib it's not reached. Similarly, in without brain mets, it's 11 months in crizotinib arm, while it is not reached in the lorlatinib arm. Time to intracranial progression was also significantly longer in the lorlatinib. You can see in 36 months, at 36 months, 92.3% versus 37.7%. It is almost 3 times better in the longer in the lorlatinib. And this is BICR assessed intracranial time to progression in patient with a baseline brain metastasis. Median PFS is not reached in lorlatinib, while it is 7 months in crizotinib. And when there is no baseline brain metastasis, crizotinib arm, it was median PFS of 30 months. 30 months versus 7 months, while it is not reached in both the condition in the lorlatinib arm. So in summary, overall response rate is 77.2% versus 58.5%, better in the lorlatinib, and complete response is almost only 2%. While in the patient with the brain metastasis at the baseline, confirmed intracranial overall response rate was 65% versus 17.9%, almost 4 times better in the lorlatinib arm, and complete intracranial response was seen in 60% of the patient. Now come to the adverse event. Adverse events are comparable with the crizotinib. Grade 3 and grade 4 adverse events were 75% versus 57%, slightly higher in the lorlatinib arm, and the treatment-related death was in 2 patients in the lorlatinib arm, while there was no treatment-related death in the crizotinib patients. Temporary discontinuation is also more in the lorlatinib arm. However, permanent treatment discontinuation are more in crizotinib, which are almost similar. In safety profile, edema, weight gain, hypercholesterolemia, hypertriglycemia, peripheral neuropathy, and cognitive effect, these adverse events are more in the lorlatinib arm. While diarrhea, nausea, vomiting, vision disorder, transaminitis, these side effects are more common in the crizotinib arm. So safety profile of lorlatinib was similar to that reported in the interim analysis of the 18 months. So we have not faced any new safety challenges during these 18 months further follow-up. So this is a slide for the summarizing the 18-month versus 36-month lorlatinib arms. PFS is hazard ratio is 0.28 versus 0.27. Overall response rate is 77%. Time to intracranial progression hazard ratio is also 0.08. Intracranial response rate 59.5%. And adverse event leading to permanent treatment discontinuation was 7% was at the 18th month, and while it is only 7.4, only 0.4% increased. So now we can compare the first line, all first line LPKs each other. You can see in this side, we can see overall response rate as best in the alectinib. Apart from this, in each and every aspect, lorlatinib performed better. You can see CNS CR rate is 38% in alectinib, 11% in brigatinib, while it is 71% in the lorlatinib. And median PFS is also approximately 24 to 25 months in alectinib, brigatinib, and certinib, while it has not been reached in the lorlatinib as per the Crown trial. These the summary of the principal adverse event of the different first line ALK TKI, alectinib, brigatinib, and certinib, and lorlatinib, and we can optimize the treatment as per the treatment profile. Now, network meta-analysis systemic review was done to compare the lorlatinib with the brigatinib and alectinib, and in this network meta-analysis, it was seen that lorlatinib is better than brigatinib and alectinib in all the treatment-naive patient. So in Indian data for the lorlatinib in Indian center, we can see when lorlatinib was given in this previously treated patient and was 41. This study was done in Tata Memorial Hospital, and we can see clinical benefit was 73% patient, 73% of the patient. This updated NCCN guideline to patient with the ALK rearrangement. If patient was diagnosed before the starting any treatment, then preferred first line treatment is alectinib, brigatinib, lorlatinib, and ceritinib. And if patient already started on the first line systemic therapy, then first we have to complete the planned systemic therapy, including maintenance therapy, or we can interrupt followed by this thing, alectinib, brigatinib, lorlatinib, ceritinib, and any first line ALK inhibitor we can start. So this is the treatment landscape, which is rapidly evolving due to new invention, new drugs. You can see previously sequencing was done with the crizotinib followed by ceritinib, then lorlatinib, crizotinib, alectinib, lorlatinib. Now we can see at the baseline lorlatinib and the first line PFS is better than all these sequential therapies of the ALK inhibitors. So in conclusion, with approximately 18 months of the additional follow-up since the interim analysis of the phase 3 Crown study, lorlatinib continued to show the superior overall and intracranial efficacy in comparison with the crizotinib in ALK positive patient. And these benefits is seen in the both whether the patient had baseline brain metastasis or not. And there is no safety signal, but we have seen. So these updated long-term data from the Crown study confirm the efficacy of lorlatinib over crizotinib in patient with treatment-naive ALK positive NSCLC. Thank you.